Welcome to this second video of Unit 2 of the module on the possibility of narrative-based medicine in spiritual care. In the previous unit, we looked at some of the theoretical underpinnings of narrative-based medicine. In the first of the videos in this Unit 2, we have seen how, despite the emphasis on spiritual care, there is a low frequency of spiritual care in clinical settings. We also look at some of the barriers that prevented spirituality from being part of care provided to people who are healed. On this basis, we will now try to analyze a series of tools that, based on narrative-based medicine, can help to change this situation. To do so, we will begin with the possibilities that narratives have with respect to help professionals themselves and caregivers in general. Both in the literature and in clinical practice, many suggestions have been made on how to improve spiritual care by professionals' health, for example, by reinforcing information or developing specific studies both at university and through complementarity training. We saw in the previous video that lack of training was one of the most important problems in attending to spirituality. Within this field of training, we are now going to focus on the barrier of health professionals not receiving formal guidance or how to communicate effectively with patients and families about spiritual concerns, making it impossible to address these more subjective needs in the absence of communication. Nowadays, healthcare professionals are characterized by basing their daily clinical practice on technology, often giving greater importance to the clinical history and complementary tests that do what the patient must tell us or share to us. To find an explication for this situation, we must go back to the emergence of the modern clinic at the end of the 18th century, a time when scientist medicine was introduced, where the patient experience and subjectivities were completely vanished. Active listening and conversation as a primary diagnostic tool were left behind. In this scenario, personal experience has been relegated to the periphery on an almost anecdotal level, distancing us from personal sufferings, meanings, and contradiction, and orienting us toward what was called evidence-based practice, a paradigm that completely inhibits any interest in spiritual aspect. Because of the above, professionals do not acquire adequate communication skill, which leads to difficulties in initiating conversation about abstract topics such as spirituality, and difficulties in listening to what the patient must tell us about it. However, as we are seeing, from the 1990 onwards, a movement emerged that attempted a change of direction. Under the name of narrative-based medicine, MMB, a trend emerged whose aim was precisely to rescue the narrative and the patient experience, shortening the distance between knowing about the illness and understanding the experience. The narrative-based medicine assumes certain limits of objectivity in the clinical method, adding to the diagnosis exercise a matter left of evidence in terms of clinical trials and more of interpreted histories. The movement has some importance, especially in Anglo-Saxon countries, even finding acceptance by the World Health Organization, which has underlined how a medicine based on illness narratives can allow to integrate the disease-centered and biomedical approach with the illness and the disease-centered approach, examining respectively the individual experience and the social meaning of the illness. In this way, the understanding of the part of healthcare professional and the openness to another person's emotion that narrative-based medicine enables is understood as a possibility to rehumanize medicine and thereby attend to factors such as spirituality. In contemporary healthcare models, which sometimes fail to provide holistic and patient-centered care, such foundation of narrative medicine offers the opportunity to improve clinical care and thereby promote patient well-being by embracing verbalization. For the patient, verbalizing the experience he or she is going through a salutary effect. It should be borne in mind that a patient is not only looking for symptom treatment and safe environment, but it is also anxious to be understood and to find meaning in what is happening to them. The effect is also positive for the listener, in this case the health professional. The patient narratives help them to better understand what is happening to them, their own process with the illness. Narrative thus counteracts the biographical rupture caused by the illness, says Annalie Absacks. For health professional, getting to know the affected person narrative thus contributes to a better understanding of how he or she experienced the illness, because in the context of narrative medicine, each patient is unique. Through emphatic listening and narrative, we try to discover their fears, feelings, and emotions in order to improve and strengthen the doctor-patient relationship, thereby also improving aspects such as spirituality. It is not enough to practice scientific medicine based on the highest scientific rigor if there is no humanistic faith that personalizes, individualizes, and contextualizes each medical act. There is no point in knowing the things and symptoms if we do not know the biography that accompanies them. We could summarize. However, in order to be able to approach patient narrative, it is also necessary to become aware of our position, our preconceived ideas, prejudices, our past history, culture, knowledge, experience that have shaped our personality. To reach a level of awareness that allows us to identify the possible difference and similarities between us and the other, something that will facilitate our openness to the position of the other. To achieve this, we believe that narratives are important in a double sense, since it is also important to work on those narratives that are specific to health professionals. An effort has been made to investigate the value of personal narratives in nursing clinical settings, for example. The conclusion of these studies are that personal narrative is a useful tool in practice and, more important, a way to improve the relationship with the patient. Nurses must pay attention to their own biopsychological and spiritual issues to meet the spiritual needs of others. Some studies have pointed out that health professionals' own spiritual lives are an important possibility to get closer to patient narratives. Finding from studies of spiritual care provided by both palliative care and intensive care nurses reiterate that nurses' own spirituality influence their practice of spiritual care. Sense and skill for spiritual communication include the ability to assess the patient's spiritual needs, compassionate presence, appropriate referral to spiritual care providers, but also self-awareness, which will give us the ability to have clinical conversation about the person's spirituality. Thus, training in narrative-based medicine can help us in this regard, fulfilling the dual purpose of enabling listening, but also paving the way for us to listen to ourselves. From these tools, openness as health professional allows us access to the patient understanding of their being in the world, including their interpretation of their situation, their spiritual needs, and their wishes regarding their present state of illness.